Hello, everyone, and welcome to our module on the normal structure and function of the musculoskeletal system. So, this is the first video of our musculoskeletal system series, and in this video, we'll study about the normal anatomy and physiology of the musculoskeletal system, the basic histology, and basic pathological conditions. So, welcome to the Musculoskeletal System lecture, foundation lecture. In this video, we will build the conceptual base needed to understand the entire musculoskeletal system. Rather than memorizing isolated anatomy facts, we will focus on mechanisms. So, we will start with embryological development and then move to bone formation, bone histology, muscle physiology, neuromuscular junction functioning, and finally nerve localization and clinically integrate all of these things. If you understand these mechanisms clearly, you will be able to solve almost all most of the USMLE and NEET PG questions, even if you have never seen the exact questions before. So, coming to the embryological origin of the musculoskeletal system, the musculoskeletal system originates primarily from the mesoderm. So, paraxial mesoderm forms somites. These somites differentiate into three components. The sclerotome forms the vertebrae and the ribs, myotome forms skeletal muscles, and the dermatome forms the dermis of the skin. The lateral plate mesoderm, whereas the lateral plate mesoderm contributes to limb bones and connective tissues. Neural crest cells contribute to craniofacial bones. Therefore, when exam questions describe facial skeleton abnormalities, neural crest defects should come to your mind. Limb development begins during the fourth week of embryonic life. So there are three important signaling centers. The apical ectodermal ridge produces fibroblast growth factor or FGF. This controls proximodistal growth, meaning growth from the shoulder towards the fingers. The zone of polarizing activity produces sonic hedgehog gene. This controls anteroposterior patterning, meaning thumb to little finger orientation. WNT7A controls dorsoventral patterning, which determines the palm versus the back of the hand, the dorsoventral axis. So, any disruption in these signaling centers leads to limb malformations. Apical ectodermal ridge, proximodistal growth, zone of polarizing activity, anteroposterior patterning, and WNT7A, dorsoventral axis. Specific genes control limb patterning. Hox genes or homeobox genes determine the spatial arrangement of the limb segments. Mutation of Hox D13 can cause synpolydactyly, which means fused and extra digits. FGFR3 mutation. FGFR3 generally inhibits chondrocyte proliferation. Mutation of this receptors leads to achondroplasia, which is the most common form of dwarfism. Achondroplasia is the most common form of dwarfism. BMP signaling causes apoptosis between developing digits. Failure of apoptosis results in syndactyly, which is webbing of fingers. Two mechanisms form bone. Intramembranous ossification converts mesenchymal cells directly into osteoblasts. This forms flat bones, such as skull bones, whereas endochondral ossification forms long bones. In this process, a cartilage template is gradually replaced by bone. The epiphyseal growth plate uses endochondral ossification for its growth. Therefore, diseases affecting this process alter the length of long bones only. Bone exists in two structural forms. Cortical bone is dense and provides mechanical strength, whereas trabecular bone is spongy and is metabolically active. Because it is metabolically active, it is the common site of osteoporosis. The fundamental structural unit of compact bone is the osteon, also called the Haversian system. It contains a central canal which is surrounded by concentric lamellae of bone matrix. So this is the central canal which are surrounded by concentric lamellae. Osteoblasts are bone-forming cells that synthesize osteoid, which is mainly type 1 collagen. Osteocytes are mature osteoblasts that are trapped in bone matrix. They function as mechanosensors that respond to mechanical stress, whereas osteoclasts resorb bone. They are multinucleated cells which are derived from the monocyte macrophage lineage. Bone remodeling is regulated through rank signaling pathway. Rank signaling pathway. Osteoblasts produce rank L, which is also called as the rank ligand. This binds to rank. This rank ligand binds to rank receptors on the osteoclasts and activates bone resorption. Rank L from osteoblasts activates rank on osteoclasts and initiates bone resorption. Osteoprotegrin acts as a decoy receptor and blocks this rank ligand. So, whenever uh, this osteoprotegrin levels are regulated in the body, you are indirectly regulating how the bone resorption or remodeling is happening inside. Estrogen increases osteoprotegrin levels. Therefore, estrogen suppresses osteoclast activity and helps maintain bone density. Whereas in postmenopausal women, as soon as there is a fall in the estrogen levels in their body, what happens is the osteoprotegrin levels decrease or fall, which leads to a reduction in the osteoprotegrin levels. And reduction in osteoprotegrin levels indirectly leads to uh, reduced rank ligand binding, which leads to increased bone resorption. This balance determines bone density and the risk of osteoporosis. Coming to hormonal regulation of bone, parathyroid hormone increases rank ligand expression, indirectly stimulating osteoclasts. So, parathyroid hormone, we all know that this parathyroid hormone increases calcium levels in the body by increasing bone resorption. Vitamin D increases intestinal calcium absorption and supports bone mineralization. Calcitonin inhibits osteoclasts, although its physiological role in adults is limited. And chronically elevated parathyroid hormone levels can lead to bone loss, whereas intermittent parathyroid hormone level elevation can stimulate bone formation because whenever there's intermittent hyperparathyroid hyperparathyroidism, what happens is some amount of calcium is released into the bloodstream. So this calcium then, after entering the bloodstream, it leads to bone remodeling and bone uh, generation, new bone formation by the osteoblast and leads to bone growth. Bone remodeling occurs continuously and involves four phases. Bone remodeling occurs continuously and involves four phases. First, activation occurs, then osteoclasts resorb the bone. This is followed by reversal and finally osteoblast-mediated bone formation. Mechanical loading stimulates bone formation, whereas disuse leads to bone loss. Clinical correlation can be understood where an astronaut who has gone into space will go through bone loss because of reduced mechanical stress because there's no gravity when they go to the space. So as a result of that, what happens is that there is reduced mechanical stress, and whenever there's reduced mechanical stress or whenever there's disuse, it leads to bone loss. At the neuromuscular junction, an action potential reaches the motor neuron terminal. Voltage-gated calcium channels open and then calcium enters the neuron. This triggers the release of acetylcholine into the synaptic cleft. So after this acetylcholine is released into the synaptic cleft, acetylcholine binds to nicotinic receptors on the muscle cell membrane, which causes sodium influx and depolarization. Action potential reaches the motor neuron terminal. Voltage-gated calcium channels open. Calcium influx triggers acetylcholine release. Acetylcholine binds nicotinic receptors on muscle. Sodium influx then leads to end plate potential or depolarization. Membrane action potential is generated as a result of depolarization of the postsynaptic membrane. So, uh, we need to remember that this nicotinic receptor is a ligand-gated sodium channel, and whenever this nicotinic receptor is stimulated through binding with acetylcholine, what happens is that this sodium channel opens, and there is influx of sodium, which leads to depolarization eventually. Now, coming to the excitation contraction coupling in a skeletal muscle, the muscle action potential travels down the T tubules in the first place. So, after this muscle action potential travels down the T tubules, the dihydropyridine receptor senses the voltage change and mechanically activates the ryanodin receptor. And then, because of the activation of this ryanodin receptor, what happens is calcium is released from the sarcoplasmic reticulum, and this calcium release initiates muscle contraction. Action potential, DHPR is activated, direct mechanical coupling to ryanodin receptor, calcium is released from sarcoplasmic reticulum, which leads to contraction eventually. Uh, Muscle contraction occurs through sliding of actin and myosin filaments. During contraction, the sarcomere shortens. The A band. So here we have something called as the A band. The A band remains constant while the I band shortens. The A band remains constant, whereas the I band shortens. ATP is required for the attachment of myosin. For ATP is required for the detachment of myosin heads. Lack of ATP causes rigor mortis. So ATP, whenever there's muscle contraction and relaxation happening, ATP is needed for both uh, muscle contraction and also muscle relaxation. So at the beginning, calcium is released from the sarcoplasmic reticulum, and by the time the muscle relaxation is happening, calcium re-enters the sarcoplasmic reticulum again. Muscle relaxation occurs when calcium is pumped back into the sarcoplasmic reticulum by the SERCA pump, SERCA, sarcoendoplasmic reticulum calcium ATPase. Tropomyosin then blocks the actin binding sites, and as a result of that, contraction stops. Energy is required for contraction and relaxation. Malignant hyperthermia leads to a defective ryanodin receptor, and as a result of defective ryanodin receptor, what happens is there is uncontrolled calcium release from the sarcoplasmic reticulum. So this is the key feature to remember about malignant hyperthermia. There are two main types of muscle fibers. Type 1 fibers are slow twitch fibers that rely on oxidative metabolism and resist fatigue, whereas type 2 fibers are fast twitch fibers that produce powerful contractions but fatigue quickly. Type 1 fibers are mainly oxidative, whereas type 2 fibers are mainly glycolytic. Type 1 fibers have increased myoglobin and mitochondrial content, whereas type 2 fibers have comparatively less mitochondria and myoglobin content. These type 1 fibers are mainly seen in marathon runners, whereas type 2 fibers, powerful yet rapidly undergo fatigue. So these are seen in people who do more of sprinting or weightlifting or resistance training. So high yield pattern in this topic is that endurance training increases type 1 characteristics. Uh, Myasthenia gravis is a neuromuscular junction disorder that affects the postsynaptic side of the synapse. So, in this disease, immune system produces antibodies against nicotinic acetylcholine receptors on the muscle cell membrane. Because these receptors are destroyed or blocked, acetylcholine released from the nerve cannot effectively stimulate muscle contraction. So, as a result of that, what happens clinically? This produces muscle weakness that worsens with repeated activity and improves with rest. Muscles most commonly affected are the extraocular muscles. So patients often present with ptosis and diplopia. A classic diagnostic feature is improvement in muscle strength after administration of acetylcholinesterase, ACH esterase inhibitors, such as edrophonium. Because whenever you give acetylcholinesterase inhibitors, what happens is there is increased availability of acetylcholine at the synaptic junctions, at the neuromuscular synaptic junctions, which leads to reduced weakness. Whereas Lambert-Eaton myasthenic syndrome is another neuromuscular junction disorder, but the problem occurs on the presynaptic side, whereas myasthenia gravis is problem occurring on the postsynaptic side. This Lambert-Eaton myasthenic syndrome is mainly concerned with the presynaptic side. Here, antibodies attack voltage-gated calcium channels in the nerve terminal because calcium entry is required for acetylcholine release. This leads to reduced acetylcholine release. Unlike myasthenia gravis, muscle weakness actually improves with repeated activity because calcium gradually accumulates in the nerve terminal. Calcium gradually accumulates in the nerve terminal. This condition is often associated with small cell lung cancer, making it an important paraneoplastic syndrome. Malignant hyperthermia is a genetic disorder which is caused by mutation of the ryanodin receptor in the skeletal muscle. When susceptible individuals are exposed to triggering events such as succinylcholine or volatile anesthetics, excessive calcium is released from the sarcoplasmic reticulum. This leads to sustained muscle contraction, which with increased metabolic activity, hyperthermia, and severe acidosis. The treatment for malignant hyperthermia is dantrolene, which inhibits calcium release from the sarcoplasmic reticulum. Dantrolene inhibits calcium release from the sarcoplasmic reticulum. Neuromuscular blocking agents are used during surgery to induce muscle relaxation. Succinylcholine is a depolarizing agent that causes persistent depolarization of the muscle membrane, preventing further contraction. Whereas non-depolarizing agents such as rocuronium act as competitive antagonists of acetylcholine receptors. Reversal agents such as neostigmine increase acetylcholine levels by inhibiting acetylcholine esterase, while Sugammadex directly binds and inactivates certain neuromuscular blockers. Muscle contraction requires a continuous supply of energy. ATP provides immediate energy but is rapidly depleted. Creatine phosphate acts as short-term energy reserve that regenerates ATP. For sustained activity, muscles rely on glycolysis and oxidative phosphorylation. Disorders affecting glycogen metabolism, such as McArdle disease, impair energy production and can cause exercise intolerance. Now let's try to study and understand about the brachial plexus. The brachial plexus arises from the anterior rami of the spinal nerves C5 through T1. Its structure follows a sequence: roots, trunks, divisions, cords, branches. RTD-CB, RTD-CB, roots, trunks, divisions, cords, and branches. Anterior divisions supply so these are the roots, C5, C6, C7, C8, and T1. Then comes the trunks. Then comes the trunks. After trunks, we have divisions, and after divisions, we have cords: lateral cord, posterior cord, and medial cord. Uh, Anterior divisions supply the flexor components, while posterior divisions supply extensor components. When analyzing nerve injuries, it is helpful to determine which movement is lost, identify the muscle responsible for that movement, and then we can trace back to the corresponding nerve: roots, trunks, divisions, and cords. Now let's try to understand about Erb-Duchenne palsy. Erb's palsy results from injury to the upper trunk of the brachial plexus. So we have already studied. So there's an upper trunk, a lower trunk, and a medial trunk, middle trunk. So Erb's palsy results from injury to the upper trunk of the brachial plexus involving the C5 and C6 nerve roots. It often occurs during difficult childbirth when there is extensive lateral traction on the head. The affected muscles includes the deltoid, biceps, and infraspinatus. Classic posture is known as waiter's tip position with the arm adducted. Because there is loss of abduction, uh, the deficits includes loss of abduction, loss of external rotation, and loss of elbow flexion. This leads to a classic posture called as the waiter step. So waiter step is characteristic with the arm adducted. Arm adducted means it is more towards the midline of our body, internally rotated, and the forearm is extended. This is called as the waiter step deformity. Arm up, arm adducted, internally rotated, forearm is extended and pronated. Clunky palsy involves injury to the lower trunk of the brachial plexus, specifically C8 and involves the C8 and T1 nerve roots. This injury usually results from upward traction of the arm, like grabbing branch while falling and during breech delivery. The intrinsic muscles of the hand are affected, which result in a claw hand deformity. So this is a characteristic image of a claw hand deformity. If sympathetic fibers are involved, Horner syndrome may also present. Posture is total claw hand, which is characterized by hyperextension of the metacarpophalangeal joints and flexion at the interphalangeal joints. Hyperextension at the metacarpophalangeal joint and extension at the interphalangeal joints, and flexion at the interphalangeal joints. Hyperextension at the metacarpophalangeal joints, flexion at the interphalangeal joints. Now let's try to understand about radial nerve injury and how it causes wrist drop. The radial nerve travels in the radial groove of the humerus. A fracture of the mid shaft of the humerus can injure the radial nerve. This results in loss of wrist and finger extension, producing wrist drop. So, therefore, inability to extend the wrist after trauma to the humerus strongly suggests radial nerve injury. So, it occurs most commonly due to crutch compression. Whenever you sit on a chair with your arm hanging on the axilla at the edge of the chair, this can eventually lead to injury to the radial nerve at the radial groove that is present in the uh, that is present on the humerus. This can lead to compression of the radial nerve there and cause a radial nerve injury, which eventually leads to wrist drop. Now let's try to differentiate between the median nerve and the ulnar nerve injuries. The median nerve controls fine motor movements of the thumb and the lateral fingers. Injury here can produce hand of benediction when the patient attempts to make a fist. The ulnar nerve supplies the intrinsic muscles of the hand. An injury of the ulnar nerve causes clawing of the hand. A helpful distinction is that in uh, the median nerve is responsible for precision movements. There are fine motor movements, like what you need to do with your hand. So this median nerve is responsible for those kind of precision movements, while the ulnar nerve is responsible for grip strength. Median nerve is responsible for precision movements, while the ulnar nerve is responsible for grip strength. The lumbosacral plexus arises from the spinal roots of L1 through S4. Important nerves includes the femoral nerve, which controls knee extension, obturator nerve, which controls thigh adduction, superior gluteal nerve, which controls hip abduction, common peroneal nerve, which controls dorsiflexion, and the tibial nerve, which controls plantar flexion. Femoral, obturator, superior gluteal, common peroneal, and tibial. The femoral nerve originates from L2 through L4. It supplies the quadriceps muscle group, which extends the knee. Injury to this femoral nerve can lead to loss of knee extension and a reduced or absent patellar reflex. Common causes includes pelvic trauma or psoas hematoma. So, in this patient with a femoral nerve injury, the patient cannot extend their knee. Superior gluteal nerve supplies the gluteus medius and gluteus minimus muscles. These muscles stabilize the pelvis during walking. Injury to this superior gluteal nerve results in Trendelenburg sign, where the pelvis drops on the other side when standing on the affected leg. Weak side, the pelvis falls on the opposite side. The common peroneal nerve wraps around the neck of the fibula and is therefore vulnerable to injury. Damage to this common peroneal nerve leads to dorsiflexion or drop foot, yeah, producing foot drop. So patients often compensate with steppage gait uh, by lifting the leg higher while walking. This leads to loss of dorsiflexion. The classic presentation is a patient with a foot drop and the characteristic gait in this patient with injury to the common peroneal nerve is steppage gait. The tibial nerve controls plantar flexion and toe flexion. Injury to the tibial nerve results in an inability to stand or walk on toes. So, sensation over the sole of the foot may also be reduced in patients uh, whoever have underwent a tibial nerve injury. Sensory loss over the sole of the foot and compression of this tibial nerve leads to tarsal tunnel syndrome. Femoral neck fractures commonly occur in elderly patients with osteoporosis who characteristically in patients who fall on hip. The medial circumflex femoral artery supplies the femoral head. So artery at risk is the medial circumflex femoral artery. If the artery is disrupted, a vascular necrosis of the femoral head can occur. So, whenever there's shortened and externally rotated leg in a post-fall elderly patient, think about a possibility of occurrence of a fracture of the femoral neck, which leads to risk to the medial circumflex femoral artery, and complication of this risk might be a vascular necrosis of the femoral head. So, they need to be promptly managed. A mid-shaft fracture of the humerus can injure the radial nerve in the radial groove because it runs in the radial groove. So this leads to wrist drop due to loss of extensor muscle functioning. Wrist drop because of loss of extensor muscle functioning. Fractures of the surgical neck of the humerus can damage the axillary nerve. This results in impaired shoulder abduction beyond 15 degrees. For the first 15 degrees, it is the subscapularis which is doing the function, whereas beyond 15 degrees, uh, we need action of other rotator cuff muscles, and some of them are supplied by the axillary nerve. Sensory loss over a regimental badge area is a possibility in injury to the axillary nerve. A lumbar puncture is performed below the level where the spinal cord enters. In adults, the spinal cord entry typically in adults the spinal cord typically ends at L1 or L2. Therefore, lumbar puncture is safely performed at L3 or L4. L3 to L5, we can safely perform the lumbar puncture. Needle passes through the skin, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura mater, and arachnoid mater, and eventually it enters into the subarachnoid space where where from where the CSF is taken out. The spinal cord enters at L1 to L2 in adults. Different gait abnormalities help identify underlying neuromuscular problems. Trendelenburg gait indicates superior gluteal nerve injury. Steppage gait indicates common peroneal nerve injury. Antalgic gait occurs when patients avoid putting uh, weight on a painful limb, whereas waddling gait is seen in patients who have been suffering with proximal myopathy. So whenever a question mentions a gait abnormality, you just need to visualize the movement and then we can localize the nerve or muscle. In the next module, we will try to understand about a few important congenital and developmental disorders of the musculoskeletal system. For many upcoming videos on this series, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for all students. If you find it useful and wish to support its development and further enhance the quality of the videos, voluntary contributions are welcome. The link is in the description and also on the screen. You can pay with any of these payment methods. Thank you. This series is started with a motto to encourage people to sit down and read their standard books rather than just watching endless lectures that are available all over outside in the market. Because when we just passively watch lectures, all our time and efforts are drained into just passive learning. But when you just have a brief review of what's actually important, what's actually tested on USMLE, and you just sit down with your book open, this leads to active learning. So this series is designed with a motto to get people, to buy people some time to just sit down and do their active learning and also solve questions. Do subscribe for more upcoming videos, and we'll get back to you with exciting content. Thank you.